For men weighing their options for prostate cancer treatment, there is really no one-size-fits-all solution, making it difficult for these men and their loved ones as they navigate the various treatment options. Whether that is initial treatment for prostate cancer, cancer recurrence after treatment, or even those with advanced disease. The good news is that we are continuing to move the field forward to more personalized care for prostate cancer in helping with these difficult decisions. You will want to listen in as I have Dr. Felix Feng joining us today, who will help get you up to speed with what you need to know. So the big question is this: how can men and those who care for them better educate themselves regarding prostate health, the conditions that affect the prostate, and the latest technology in managing these conditions? That is the question, and this podcast will provide the answers. On a weekly basis, we will be chatting with experts, innovators, and leaders in the field of urology, sharing useful information with the general public to improve their lives and increase their overall health. My name is Dr. Garrett Pullman, and welcome to the Prostate Health Podcast. Prostate Health Podcast is for informational purposes only. Nothing in this podcast should be construed as medical advice. By listening to the podcast, no physician-patient relationship has been formed. For more information and counseling, you must contact your personal physician or urologist with questions about your unique situation. I'm excited to be able to introduce to our Prostate Health Podcast listeners radiation oncologist Dr. Felix Feng. Following undergraduate training at Stanford University and medical school at Washington University in St. Louis, he completed a research fellowship and residency in radiation oncology at the University of Michigan, where he subsequently joined the faculty there. He was then recruited to join the faculty at the University of California, San Francisco, where he currently serves as a professor of radiation oncology, urology, and medicine, vice chair for radiation oncology, and director of the Benioff Initiative of Prostate Cancer Research. He is a prostate cancer expert who specializes in the treatment of aggressive, high-risk, and oligometastatic prostate cancers. Dr. Feng is nationally known for his approaches in using molecular biomarkers to help guide or personalize radiation therapy for patients. Dr. Feng, welcome to the Prostate Health Podcast.
Thank you for having me here.
So for men diagnosed with prostate cancer, there are various treatment options available. Can you share with our listeners what is a radiation oncologist, as well as the role that they play in the multidisciplinary prostate cancer team?
Absolutely. So there are multiple different ways to treat prostate cancer, but three of the major approaches for treating prostate cancer are surgery or radiation therapy, which I'll describe in more detail, or drug-based therapy, most often hormone therapy of sorts. And so when I describe radiation therapy, it's really the use of X-rays to treat cancer. And these X-rays work in different ways, but ultimately what they do is that they damage cells that are growing faster than others, and that by definition is cancer cells. And it's been shown that radiation therapy works actually in many different stages of prostate cancer. It works for patients who have what we call localized prostate cancer. Prostate cancer is still confined to the area of the prostate. And in that regard, it's actually an alternative to surgery in patients with low risk or intermediate risk or high risk prostate cancer. It also can be used quite effectively in patients who have been treated with surgery and have a recurrence of their prostate cancer as well. More recently, it's been utilized in patients with limited metastatic prostate cancer, and that's termed oligometastatic prostate cancer, where there's only 1 to 3 spots of prostate cancer that's gone to other parts of the body. And it's also used in the context of patients with really advanced metastatic prostate cancer, where their prostate cancer is causing pain in the bones or some symptoms somewhere else. And radiation at that point can be used to shrink an area of cancer just in one part of the body that's causing symptoms.
Yeah. Well, Dr. Feng, you have really been a national leader when it comes to personalized therapy for prostate cancer. So for an individual who is considering radiation therapy, I was going to see if you could explain what personalized therapy entails and what one could expect with this.
That's a great question. So it turns out that we use radiation therapy slightly differently depending on how aggressive a patient's prostate cancer is. And so for low-risk prostate cancer, men can be followed with active surveillance, where actually we don't do anything interventional except for just check on the tumor from time to time, and that's really the job of the urologist. But for more aggressive prostate cancers, such as intermediate risk prostate cancer, or high-risk prostate cancer, both surgery and radiation are options. Now, with intermediate and high-risk prostate cancer, for some of these cancers, we give hormone therapy in combination with the radiation, and for others, we don't. And ultimately, for the past decade or so, it's been more of a kind of formula type approach for how we treat prostate cancer. Intermediate risk prostate cancers primarily get radiation and hormone therapy, at least over the past decade, that's been true. High-risk prostate cancer patients get radiation and even more hormone therapy as well. And what we've been doing is developing biomarkers, which are molecular tests that you run on the cancer sample to be able to try to, quote unquote, personalize therapy. And so it's clear that not all intermediate risk patients need 6 months of hormone therapy. Some can be treated with radiation alone. It's clear that not all high-risk prostate cancer patients benefit from, let's say, 2 years of hormone therapy, which is kind of a standard approach for treating high-risk disease. And so the way I use biomarkers in my clinic is that if a patient is diagnosed with, let's say, a prostate cancer where they have some aggressive features, and normally I would think about giving hormone therapy, but I'm kind of on the borderline, at that point in time, the genomic data is quite important. So sometimes it helps me guide who to give, short course hormone therapy to, who not to. And similarly, if I want to think about a longer versus a shorter duration of hormone therapy with radiation, for some of the higher risk patients, sometimes the genomic biomarker helps out there. And so those are approaches for kind of personalizing radiation. We also do this in the context of patients who experienced a PSA recurrence after surgery, where we've shown that certain genomic biomarkers can actually, identify relatively well which patient should get hormone therapy at all with the radiation or not. And given the side effects of hormone therapy, that's actually really important for patients' quality of life.
Yeah. So really definitely can be useful in those scenarios. I thought maybe it'd be touched a little bit on this, but maybe kind of talk a little bit about what is the difference between a prognostic biomarker and a predictive biomarker?
Yeah, absolutely. And so a prognostic biomarker is a biomarker that is associated with clinical outcomes regardless of the treatment that's given. And so, for example, if a molecular biomarker says that a patient's cancer is aggressive and associated with poor prognosis, what that means is that that patient is at a risk for recurrence regardless of whether they get surgery or radiation up front. And so prognostic means that patient just has a cancer with a worse prognosis or worse outcome. A predictive biomarker is a biomarker that specifically predicts either response or resistance to a particular therapy. And so, for example, a biomarker that, let's say, predicts response to a specific hormone therapy may not predict response to another type of drug therapy, such as chemotherapy or so.
Yeah. In your clinical practice, I'm sure you're already finding some of these biomarkers helpful then for you.
Absolutely. Actually, nowadays, I get a lot of consultations for patients who actually might not be getting radiation therapy, but they've gotten some of these biomarker tests and they just want a more detailed explanation of the biology of their tumor, what the biomarker means, and how it should influence their management. So we routinely get a genomic biomarker on almost every prostate cancer patient we see. For low-risk patients, the biomarker can tell them maybe whether they should be getting active surveillance, or if they have more aggressive features, maybe we would lean a little bit more towards treatment. For intermediate and high-risk prostate cancer, mostly to personalize either how much or the duration of hormone therapy, or sometimes it helps guide our radiation fields. Should we radiate the lymph nodes or not? But I would say that in all these contexts, when you look at physicians, there are going to be earlier adopters of technology and later adopters of technology. So I'm an earlier adopter of technology. I would say that my practice is probably more unique in that I would say it's probably not as routine to use genomic biomarkers.
Certainly. Well, I thought while we have you on the show, I thought it'd really be great to cover a topic that often comes up with our patients, as well as see these questions pop up from time to time, even prostate cancer support groups. Now, hormonal androgen deprivation therapy is often given in conjunction with radiation treatment. And for our listeners, what that means is, again, typically using medication to bring a man's testosterone level down to what we call very low or castrate levels. Now, we're not actually, it's more of a medical castration, what we usually use now. But I was going to see if you could talk a little bit about the rationale behind why this is given in conjunction with the radiation treatments.
That's a great question. So if you go back, 20 years ago, it was thought that hormone therapy is a drug that goes through the whole body. And so it was thought that hormone therapy takes care of cancer cells that are outside of the area of the prostate, and things like radiation, which really we target towards the area around the prostate, would take care of the disease there. But it turns out that concept of kind of spatial cooperation really actually isn't true, because if it was the fact that hormone therapy was taking care of disease everywhere else in the body and a local therapy was taking care of the area around the prostate, then hormone therapy would be beneficial if added to surgery. And there's a lot of clinical trials that have shown that hormone therapy really doesn't add to surgery. And so a number of years ago, various teams of investigators led by Karen Knudsen at Thomas Jefferson and myself and Charles Sawyers at Memorial Sloan Kettering, we studied the biology of prostate cancer in the laboratory. And what we found is that testosterone, which is the major male hormone, drives prostate cancer, and it causes prostate cancer to increase a biological process called DNA repair. Okay. And the reason why this is important is the way radiation works is that radiation causes damage of the DNA in cells that are growing too fast, which is really tumor cells or cancer cells. And so what happens is that testosterone makes prostate cancer repair damage from radiation, and therefore it makes that prostate cancer resistant to radiation. So when you give hormone therapy, you block testosterone, you make testosterone levels low, and all of a sudden that allows the radiation to be more effective at damaging the DNA in the cancer. And so the hormone therapy actually makes the radiation work biologically better, and that's the reason why we combine the two. And it's not only based on these laboratory studies, but it turns out that there have been many clinical trials that have shown that in various disease contexts, the adding hormone therapy onto radiation improves outcomes for patients in terms of cure, in terms of preventing the cancer from coming back, in terms of stopping the ability of the cancer to metastasize or go to another part of the body later.
Well, that's an excellent explanation. Now, how about what do you kind of use in terms of deciding how long to have men on hormonal therapy, whether that's 6 months versus 2 to 3 years?
Yeah, so conventionally we have used kind of clinical and pathologic features to determine which men should get hormone therapy and how long. And so traditionally for low-risk prostate cancer, we certainly wouldn't give any hormone therapy, and certainly we might not give surgery or radiation. We just might follow that cancer. For men with intermediate risk prostate cancer, we break down the intermediate risk prostate cancer into two groups, one called favorable intermediate risk, one called unfavorable intermediate risk. And those designations are really based on features like what the prostate cancer looks like under the microscope, how many positive biopsies there are, what the PSA level is, et cetera. And for men with favorable intermediate risk prostate cancer, we treat with radiation alone. For men with unfavorable intermediate risk prostate cancer, we traditionally treat with radiation plus 4 to 6 months of hormone therapy. And then for men with high-risk prostate cancer, and this is defined also by how prostate cancer, the biopsy looks under the microscope or the level of PSA, what we do for those men is we treat with radiation and let's say anywhere between 18 to 36 months of hormone therapy. But, it's becoming clear that not all patients with unfavorable intermediate risk prostate cancer need 6 months, of hormone therapy. And there have been groups that have demonstrated that if you have a low chance of metastasis as identified based on a genomic biomarker, which is testing the cancer sample for various kind of biological characteristics, if you have a low genomic classifier score and you have unfavorable intermediate risk prostate cancer, you can probably be treated with radiation alone. Similarly, if you have a low genomic classifier score with high-risk prostate cancer, you might not benefit as much from the longer duration of hormone therapy. And so one of my other positions that I didn't describe earlier is that I chair one of the large national clinical trials groups. It's called the NRG, or formerly RTOG, Cooperative Clinical Trials Group. And I oversee the prostate cancer and bladder cancer and kidney cancer portfolio for that group. And currently we have 11 phase 2 or phase 3 trials that are either accruing patients or in development. And our next stage of phase 3 studies in the context of intermediate and high-risk prostate cancer is, for example, for unfavorable intermediate risk prostate cancer patients, we will get a genomic classifier on all those patients. And based on the genomic classifier, if they have a low risk of metastasis, we will enroll patients on a phase 3 trial, large clinical trial, where they're randomized to radiation and short-term hormone therapy, which is the standard of care, or radiation alone, which is kind of a de-escalation or de-intensification of therapy. For patients who have the high genomic classifier, what we're doing is we're randomizing them to the standard of care, which is radiation and short-term hormone therapy, or that same treatment, radiation and short-term hormone therapy, plus a new, more powerful hormone therapy in this case called darolutamide. And we also have kind of the same trial design for high-risk prostate cancer where, again, based on the genomic classifier, they're actually randomized to standard of care, which is radiation and long-term hormone therapy versus a de-escalated treatment of radiation and short-term hormone therapy. If they have a high genomic classifier score, they're randomized to even more hormone therapy. And so I think that studies like this will potentially help define, who really should be getting more intensification of therapy, who should be getting less intensification of therapy.
I think it seems like you're doing a wonderful job in looking at this and really trying to personalize medicine. And, looking at that personalized medicine, what has your research group been working on recently when it comes to deciding, which patients may benefit from androgen deprivation therapy, for example, who have their PSA come back after their prostate's removed?
Yeah, so that's a great question as well. And so what we've been doing is we've been taking prostate cancer samples from men who were treated on clinical trials 15, 20 years ago. And we've been trying to identify the genomics of those cancers. And what we did was we took the samples from an old trial called RTOG 9601, and that took about over 700 patients who had a PSA recurrence, meaning their prostate cancer came back after surgery. And those patients were randomized to either radiation alone at the time of their recurrence or radiation plus 2 years of a hormone therapy called bicalutamide. And what we showed recently is that patients who had the low genomic classifier score derived no benefit from the hormone therapy. And actually, on our analysis, it may have appeared that they had slightly worse outcomes with hormone therapy. Again, we didn't have enough patients to make a strong conclusion that they did worse, but clearly they didn't do any better with hormone therapy. And so I think that there's actually pretty strong evidence now for men who have recurrence after surgery that in addition just looking at clinical and pathologic features, if they get the genomic test, they can better inform whether they should get hormone therapy or not. And that's, I get a lot of patients in my clinic, and I think it's safe to say most men really do not want hormone therapy unless they need it. And so this test kind of will tell them whether they need it or not.
Yeah, well, that's great. And so lastly, for men who have metastatic prostate cancer, again, meaning prostate cancer that's spread beyond the prostate, such as into the bones or other organs, what recent advances have you seen for men in helping personalize their treatment approaches?
I think that the entire field of prostate cancer treatment is moving towards personalization. And so if you go back a few years ago, the way that medications were given for patients with metastatic prostate cancer is you try one treatment. When it stops working, you try another treatment. When that doesn't work, you try a third treatment and so forth. And, there are some good aspects to that approach, but the bad aspect is that that's kind of a one-size-fits-all approach. And what we know is that prostate cancer differs between one patient and another. So the treatment that might work in one patient may not necessarily work in another patient. And so more recently, it's been shown that there are 3 different approaches that work in patients with metastatic prostate cancer, but only a subset of these men based on genomic or molecular features. And so, it's been shown, actually our group and others showed that about 15 to 20% of men with metastatic prostate cancer have a certain genetic alteration or genetic change in genes responsible for a biological process called DNA repair, which I described earlier. And, these are genes like BRCA1, BRCA2 that are more commonly known in the context of breast cancer. But what's been shown is that for men, with these alterations, there's a specific drug called a PARP inhibitor that actually is very, very effective in these patients. And just this past year, 2 PARP inhibitors were approved by the FDA for use in patients with metastatic prostate cancer with these particular genetic findings. In addition, the use of immunotherapy has been approved for for prostate cancer patients that harbor another genetic alteration, kind of mismatch repair deficiencies as well. And that's not just in prostate cancer, that's broadly across almost all cancers. And then the third kind of personalized approach for patients with metastatic prostate cancer is going to be a drug called an AKT inhibitor. And this was just reported just 1 or 2 months ago at an international meeting that it works in patients with a specific alteration called a PTEN deletion. So PTEN is a gene that actually plays a role in prostate cancer. What happens is that when you lose this gene or lose expression of this gene, the cancer grows faster. And there's a drug that basically targets that particular pathway to actually be effective in patients with PTEN loss. And I think I'm simplifying a little bit, but when PTEN is lost, something else is turned on, and that drug blocks that something else.
Well, I certainly applaud you and your group for the work that you're continuing to do and moving the field along in terms of personalization of therapy for prostate cancer. Dr. Feng, any final thoughts today for our listeners?
I think that we are in an exciting time in the context of advances in prostate cancer. And I think that the field as a whole, and I can't take credit for this, I've just been a part of these advances, but the field as a whole is moving towards what we call individualization of therapy. And so we believe that even though there might be 100 men who have prostate cancer, let's say, in a given hospital at a time, not all of those patients are going to benefit from the same therapies. And so whether it's in the context of localized prostate cancer or metastatic prostate cancer, we believe that there are biological features of the cancer that can be assessed with these genomic tools that can be used to personalize probably almost all stage, a treatment for all stages of prostate cancer, from treatment versus no treatment in the active surveillance setting to more treatment versus less treatment in the context of localized intermediate or high-risk prostate cancer to, hey, which different drug should you get, instead of the one that's normally used in the context of metastatic end-stage prostate cancer. And it's just been a privilege to kind of be part of research in this area. And I think that we really owe a debt of gratitude to all the patients who've enrolled on these studies nationally and internationally and have that have led to the advances that I've described.
Dr. Feng, it was indeed a pleasure having you on the show today to help educate our listeners about the advances being made for those with prostate cancer. I think I can speak on behalf of all of our listeners that we really appreciate you taking time to join us on the show. Thank you again.
Thank you for having me, Garrett. Appreciate it.
Thank you again for listening to the Prostate Health Podcast. We would love to have you join our podcast Facebook group at www.facebook.com/groups/prostate health podcast, or just use the Facebook group search function and search for the Prostate Health Podcast and ask to join. We'll see you at the next episode.